I'm Julie Gayle. I'm a women's health nurse practitioner. I'm going to be discussing the perinatal client. Some terms to be familiar with: antepartum, or you may see antepartal. It's used interchangeably with prenatal, and it signifies the time from conception to the onset of labor. Once the patient is in labor, the patient is in the intrapartal stage, and that lasts until the delivery of the baby in the placenta. After that, the postpartum period occurs, and it lasts until the woman returns to the pre-pregnancy state, which is typically about 30 months. Gestation is the number of weeks since the last menstrual period, and you can see in the other column you've got LMP and LNMP, and that stands for last menstrual period and last normal menstrual period. Abortion, this is any birth that occurs before 20 weeks gestation. It could be a spontaneous abortion, like a miscarriage, or it can be an induced or elective abortion. Stillbirth is any baby born dead after 20 weeks gestation. EDC stands for estimated date of confinement. That's what it was historically called, but there were rather negative connotations, so they changed it to EDD, which is estimated date of delivery. And then some people felt like there were some negative connotations associated with that. So you may see estimated date of birth like EDB. And then you may typically see EDC or EDD. Term, it's the normal duration of pregnancy and occurs 37 to 42 weeks gestation. A baby born after 20 weeks but before the 37th week is preterm, and a baby born after 42 weeks gestation would be postterm. Gravida is basically the number of pregnancies, and that can include the present pregnancy. So if you've got a patient who's pregnant for the second time and they're in that pregnancy, they're considered gravida too. Para is the number of deliveries after, or just the number of deliveries, and that's whether the baby's born dead or alive. Nulla gravida, nulla para, that's nulla para would be someone who has never been pregnant. Nulla para would be someone who's never delivered. Prima gravida would be first pregnancy. Prima para would be first delivery. Multigravida would be 2 or more pregnancies, and multipara would be 2 or more deliveries. The terms gravida and para refer to the pregnancies and not the baby. So when you have twins or other multiples, they're going to count as one pregnancy and one birth. So I always kind of think of the gravida para system being the para being how many times you actually empty your uterus. So if you had one baby, if you had 3 babies in there, you know, that would count. So if you've got someone who's in her second pregnancy but did deliver some twins in her prior pregnancy, she's still gravida 2, para 1. Been pregnant twice and delivered her twins, and then is currently pregnant. And I have a couple examples on the next slide. The Gtpal system will probably be the most commonly system you'll see, and basically gravida is how many times they've been pregnant. Term would be any babies born after 37 weeks. Preterm, any babies born after 20 but before 37. Abortions would be the number of pregnancies ending before 20 weeks, and that could be through a spontaneous or induced AB or abortion. Living is the number of children that are currently living. So if they had a baby that died, you know, several years ago but was a school-age child, you wouldn't include them in the living. So example 1, Ms. Smith has one child born at 38 weeks and is pregnant for the second time. At her initial prenatal visit, the nurse indicates her obstetric history is gravida 2, para 1. Then that pregnancy ends at 16 weeks gestation. So she's a gravida 2 because she's had 2 pregnancies. She had one delivery at 38 weeks, no preterm deliveries, 1 AB because of the 16-week delivery, and then 1 living, the one that was born at 38 weeks. Example 2, Ms. Jones, pregnant for the 4th time. She has a child born at 35 weeks. She lost one at 10 weeks and then gave birth to a stillborn at term. So at her initial prenatal visit, she's in her 4th pregnancy, so she's gravida 4. She has had 1 term delivery, and that was the stillborn. She's had 1 preterm delivery, the one at 35 weeks. She's had 1 AB, the one at 10 weeks, and she has 1 living, which was the one born at 35 weeks. So she's gravida 4, paired 2, in gravida 4, 1 term, 1 preterm, 1 AB, 1 living. So this may be a review, but what is a trimester? Basically, you know, the pregnancy is divided into 3-month segments called trimester. So you can say technically your patient is pregnant for 9 full months. The first 13 weeks are the first trimester, and this is the ideal time for the patient to begin prenatal care. And we'll talk about that. Second trimester are 14 to 27 weeks gestation. Third trimester begins at 28 weeks to term. And we'll talk about the different goals and education for each trimester. So this is just a review of some of the hormones in pregnancy. The HCG, you know, this is secreted from the trophoblast in early pregnancy, and this is what will indicate a positive pregnancy test. The HCG early stimulates progesterone and estrogen by the corpus luteum and then the placenta a little bit later to maintain a pregnancy. The human placental lactogen, that's also made by the trophoblast. It's antagonistic to insulin and increases free fatty acids for maternal metabolic needs and decreases maternal metabolism of glucose in order to meet the baby's needs. Estrogen, that's secreted first by the corpus luteum and then by the placenta around 8 weeks, stimulates the endometrium, and it also stimulates breast growth. Progesterone is secreted by the corpus luteum as well, and then the placenta is considered the hormone of pregnancy. It inhibits uterine contractions, maintains the endometrium, and also aids in breast development. Relaxin, this hormone inhibits contractions, it softens the cervix, and remodels pelvic structures. It also is a hormone that, well, never mind, I'm thinking something else. Prostaglandins, these are lipids in high levels in pregnancy. It maintains placental reduced vascular resistance, and it can actually initiate labor. Some of your patients may be prenatal patients, and some of them may be in their preconception years, and a lot of times what you're doing in those visits, the screening, the education, are going to be the same. But talking about prenatal care, the goal of prenatal care is really overall to reduce maternal and fetal mortality and morbidity. The purpose is to deliver risk screening, health promotion, and effective interventions. And for preconception, you want to reduce risk to health before subsequent pregnancies and beyond the childbearing years. Late prenatal care and no prenatal care are associated oftentimes with poor maternal and neonatal outcomes. Specific conditions to which poor maternal and neonatal outcomes are often attributed to include preterm labor, delivery, infection, intrauterine growth restriction, hypertension, preeclampsia, diabetes, birth defects, multiple gestation, abnormal placentation. If you work in any practice that you come across women of childbearing years, you should include some type of assessment and counseling about appropriate medical care and risk behaviors in order to optimize any future pregnancies. We know that half of all pregnancies are unplanned. So if anything, you could assist them in contraception and trying to manage their medical problems prior to getting pregnant or any other preconceptional risk. In a preconception visit, it includes the same history taking that is done at the initial prenatal visit, and we'll talk about it. And this is really because the goals of both the prenatal and the preconception care visit is healthy women and optimal birth outcomes. And this is just kind of a general little template of any kind of health screening for women of reproductive age. So routine prenatal or antenatal care provides the opportunity for screening for high-risk behaviors or conditions, periodic assessment of the pregnant patient, and education. So antepartum care should include, and we're going to talk about each one of these, the diagnosis of pregnancy, how to diagnose pregnancy and determine the gestational age, assessment of maternal and fetal well-being, monitoring the progress of pregnancy with appropriate exams and screening, providing the patient with education about pregnancy and potential complications, and preparing the patient for the intrapartal and postpartal period. Just to mention, in the diagnosis of pregnancy, you're going to have presumptive, probable, and positive signs of pregnancy. Presumptive, they are not, proof of pregnancy. They're subjective. It can be morning sickness, like nausea, vomiting, breast tenderness. The patient reports of amenorrhea, urinary frequency, excessive fatigue, and quickening. And to remind you, quickening is just fetal movements that the mother reports. Typically occurs from 16 to 22 weeks. They may report that. It seems like the multigravidas may feel it sooner, whereas the primogravidas may feel a little bit later. And I think that's more just because of, the woman who's had a baby before. She is familiar and she's aware of what she's feeling. Probable signs are objective. They're a little bit more diagnostic than presumptive. But again, it's not offering the definitive diagnosis of pregnancy. It's just kind of supporting evidence. Good L sign, that's basically softening of the cervix. Hagar's is also a sign of the place between the cervix and the uterus softening. The Chadwick is the bluish, blue to purple discoloration of the cervix. Braxton Hicks contractions, they can be palpated. Pigment changes, the mother may have the linea nigra, which is the kind of like this little strip of dark pigmentation along the umbilicus. Chlasma could just be patches of darkened pigmentation, usually around the face, cheeks, and this is all due to the hormonal changes. And then stretch marks or the abdominal stria, and then they could have a positive pregnancy test. Just to mention about pregnancy tests, you've got the urine pregnancy test that measures HCG, and it can detect levels of 25 and greater. It typically will be positive approximately 4 weeks from the last menstrual period, and that's usually, the time when the patient is kind of waiting and hadn't started her cycle. Serum pregnancy, that measures the beta HCG, which has a question mark, but it's supposed to be a beta sign. This is more specific and sensitive. You can have a positive pregnancy test approximately 8 to 10 days post-conception, and then usually the levels will double approximately every 2 days until about 8 weeks, and then they'll start to decline. The tracking the levels like that, where you're kind of maybe checking and seeing if they're doubling, that could be just a way to try to differentiate if you've got a normal or abnormal pregnancy. So positive signs, these are conclusive proof of pregnancy, and they're completely based upon objective findings from the examiner. They're typically not present till the 3rd or 4th month into pregnancy. So positive signs would be actual hearing the fetal heart tones, and this can be done. You can do it with a transvaginal ultrasound pretty early on. If you use a handheld Doppler, you may not hear it till 10 to 12 weeks, and even 10, that's usually on a pretty, small person, 10 to 12 weeks. Another positive sign would be actual fetal movements felt by the examiner, and then of course ultrasound evidence of an embryo or a fetus. So, those patients that come in really early and you do an ultrasound and they just have a gestational sac, you don't really see, that's not, that could fall into the probable if it's around the gestation you think. Determining accurate gestational age is very important, and this is because of preterm delivery. There's a lot of risks associated with preterm delivery. So getting the dates right is very important. This can be done, well, first you can, if you've got a patient that knows the first day of their last menstrual period and they're pretty regular in their cycles, you can apply Naples Rule, and you just begin with the first day of the last menstrual period, subtract 3 months and add 7 days, and you can see an example right there. This is the same premise that the little gestational wheels and a lot of the pregnancy apps that the patients use. And again, it's really only reliable if you're dealing with, regular menstrual cycles. If it's somebody that, got off the pill and really didn't have a regular cycle or get back normal cycles, it may be hard to determine. So in addition to calculating based on their last menstrual period, thank goodness we had the ultrasound. And this slide's kind of randomly put here, but before I talk about ultrasound, and this, because this does kind of help you maybe on that initial visit if you've got somebody, come in and you're not sure how far pregnant they are. You can do the pelvic exam, determine the uterine size, and then you can do fundal height measurement. Typically around 20 weeks, the top of the uterus, the fundus, will be at the umbilicus. After about 20 weeks, every visit that the patient comes to until that last couple weeks, you'll be measuring fundal heights, and you just measure from the symphysis pubis, that bone, till the top of the uterus, and the centimeters should correlate with their gestational age. If you have a patient who, they may just kind of watch the trend, but if they're, more than 3 weeks off, like all of a sudden, or becoming 3 weeks off, kind of in their trend or whatever, you may just do an ultrasound to look at fetal growth. So ultrasound, the most accurate determination of gestational age is going to be done measuring a crown rump length and at about 8 to 12 weeks gestation. And this is great if the patient has had irregular cycles and they seek prenatal care in that first trimester. And as you get further along, it's just not as accurate. Also with ultrasound, you can determine if you've got an intrauterine pregnancy. You can assess for fetal cardiac activity and fetal heart tones. And then I just kind of put, to mention also, typically you're going to do a transvaginal ultrasound early on, and of course you want to make sure that they have an empty bladder for that. Transabdominal, that's more the ultrasound they'll do at around 20 weeks, and you would want them to have a full bladder with that. And then I just put under there typically what you'll see at each gestation. So at 4 to 5 weeks, you should see a gestational sac. By 5 to 6, a yolk sac. By 6 to 7, a fetal pole, and of course by 6 to 7 too, some cardiac activity. Or you may see some people it may be a fetal pole, and then somebody it may be cardiac activity. But then definitely by 8 weeks you should be seeing the baby and able to do a good crown rump length, and that's basically from the baby's head to the end. So the ultrasound is a valuable tool, especially in the diagnosis of ectopic pregnancy. Ectopic pregnancy is basically the implantation of a fertilized ovum in a site other than the endometrial lining of the uterus. It accounts for 2% of all first trimester pregnancies and 6% of all pregnancy-related deaths. Now, this was based on an older statistics, and it was reported by ACOG, the American College of Obstetricians and Gynecologists. But we know the prevalence could be a little bit more because women sometimes will go and be managed through the office and then sometimes through the ER. It's important to be able to rule this out and diagnose ectopic pregnancy, because early detection can lead to successful management and the conservation of fertility. As I mentioned, the ectopic pregnancy is an implantation anywhere but in the uterus. 97% of the time it's in the fallopian tube, but it can occur in the cervix, the ovary, the abdominal cavity. Risk factors associated with ectopic pregnancy include previous or frequent genital tract infections, possibly maybe that led to pelvic inflammatory disease, and so they had some scarring in the tubes. If they've had a previous ectopic pregnancy, definitely be alert to the possibility of ectopic again, because the recurrence rate is 7 to 15%. IUDs, they could be at risk if they have IUD or intrauterine device. And any in utero exposure to DES, if the patient has had that, which we don't really have patients that have come in contact with that as much as probably when my mom was growing up. Also be alert to the patient that comes in who's had a tubal sterilization, and this is I've just run pregnancy tests on all women of reproductive age, even if they've had a tubal. A third of pregnancies that occur after a failed tubal are ectopic pregnancies. Infertility and the use of assisted reproductive technologies is a risk. Any previous pelvic or abdominal surgery, and then smoking. So basically the common factor among all these is that there's potentially a pathologic fallopian tube as to where that can occur. After the implant of the pregnancy, the embryo will grow, but no decidua is present, so rupture is inevitable, and that's why prompt diagnosis is important. The clinical presentation, it's going to depend on if you're dealing with a ruptured or non-ruptured ectopic. They'll present with classic pregnancy signs like amenorrhea, nausea, breast tenderness. They may or may not have taken a home pregnancy test. They'll present with abdominal or pelvic pain. Be alert to the possibility that they could be bleeding, or maybe they haven't missed a cycle but have been having either spotting or heavy menstrual bleeding. They'll possibly have some abdominal tenderness, a palpable pelvic mass, cervical motion tenderness on exam. If you're dealing with a rupture, they could complain of shoulder pain as the hemorrhage becomes more extensive and irritates the diaphragm. They're usually afebrile. Also with rupture, they could have signs and symptoms of hypovolemia and shock. So if the patient presents, you'll do a pregnancy test and perform an ultrasound. So sometimes you can do ultrasound and find the ectopic pregnancy. Sometimes you can determine that you've got a normal intrauterine pregnancy. Just because you are able to find a intrauterine pregnancy or IUP, you don't rule out the possibility that there could be an ectopic pregnancy, especially if you're dealing with infertility patients, because with the use of assistive reproductive technologies or ARTs, there's been an increased incidence of heterotopic pregnancies. Basically, on the pregnancy test, if you have an empty or non-conclusive ultrasound, you would need to measure serial beta-HCG levels. Remember, I mentioned that in a normal pregnancy, they're going to double every 2 to 4 days. I would recommend repeating the ultrasound. If you draw a quantitative and, you know, their history is kind of consistent that you should, you know, see a gestational sac and they've got a beta of greater than 1,500 to 2,000, then you should be able to see a gestational sac. So you'd know that you'd be dealing with an abnormal pregnancy. In the case of the unstable patient, you just go probably straight to laparoscopy or laparotomy for diagnosis and treatment. So your treatment is going to depend upon the ability of the patient to follow up as well as the presenting history and physical. It can be conservative if you diagnose it, of course, before rupture. People that are candidates for expectant management need to know about the risk of tubal rupture and hemorrhage. They should be asymptomatic and start to show some objective signs of resolution, such as decreasing beta-HCGs. In general, patients with early tubal gestations and lower betas are the best candidates for expectant management. And this is because approximately 20 to 30% of ectopics are associated with decreasing levels at the time of presentation. If the initial beta is less than 200, about 88% of those patients will experience spontaneous resolution. Some reasons to abandon expectant treatment would be if they started having an increased amount of pain or had intractable pain, failure of the beta-HCGs to decrease, and of course tubal rupture. Medical therapy includes Methotrexate. This can be administered IM as a single dose, or in higher betas, usually greater than 5,000, it may be a multi-dose regimen. The candidate for Methotrexate would be the women with the confirmed or high suspicion of ectopic pregnancy who are hemodynamically stable with an unruptured mass. And you can see on this slide the contraindications to Methotrexate. And you can see that if you perform ultrasound and they've got a gestational sac larger than 3.5 centimeters, you know, that's not your ideal candidate. And then, of course, any cardiac motion. This patient should also be able to be followed. So sometimes the ER is not the ideal place to administer it, but I have known patients to actually do that and actually follow up in the ER. As I mentioned, it's typically administered IM as a single dose. Then you'll need to have the patient follow up post-treatment to be evaluating the beta-HCGs, and they should be declining until they're at non-pregnant levels. If it's a multi-dose regimen, you need to educate the patient on the side effects of Methotrexate, which can be bone marrow suppression, hepatotoxicity, alopecia, and photosensitivity, so they should avoid sunlight while under treatment. Again, with a multi-dose regimen, you'll need to monitor serial betas, usually weekly until undetected. And then those patients who will want to monitor the blood count, platelet count, and then liver enzymes as well. Also, and I'll get into a little bit of the surgical treatment, which is really what I already mentioned, the laparoscopy and the laparotomy. Laparotomy, you're more likely, you know, in the patient that's bleeding and having hemodynamic instability. You hope that it doesn't involve a salpinectomy, which is a removal of the tube, but they can do a dissection and conserve the tube, and that's the goal, to promote a rapid recovery and preserve their fertility. If they're Rh negative, so I would typically draw the blood type in Rh whenever you draw a beta, definitely. If they're Rh negative, you'll need to administer RhoGAM. And this is again why the follow-up is so important. The patient also needs to be aware that that they are at risk for another ectopic pregnancy, and you may discuss even some contraception for 2 to 3 months. Again, you're going to follow this patient until the betas are at non-pregnant levels. So whether you're seeing a prenatal patient or a patient of childbearing years, and you know, you're kind of looking at preconception, their age and their history is going to determine their baseline risk. So if you've got a really young patient or an older patient on the spectrum of childbearing years, then you know they're at risk for certain OB conditions such as preeclampsia. In the preconception visit, you definitely want to discuss their plans for pregnancy. In the prenatal and preconception visit, you need to determine any history, like medical history, such as high blood pressure, asthma. Make sure they're, you know, controlled prior to pregnancy. You need to determine their surgical history, if they've had any, of course, pelvic abdominal surgeries, any problems with anesthesia, any psychiatric disorders, because, you know, they can worsen during pregnancy, and a neurological history. Are they any seizure disorder, because there are certain medications that are antagonistic to the folic acid, and that would be very important for them to have adequate folic acid prior to conception to prevent neurotube defects. A good obstetrical history. Not only, of course, you want to look at their current pregnancy. If they are pregnant, are they getting adequate prenatal care? But any previous pregnancy history of loss, fetal death, if they've had, you know, did they have preeclampsia in the last pregnancy, problems with their sugar, because they're, of course, at risk. Do a good family and genetic history, and that's going to include the patient's partner and his family. You need to know if there's been any babies born with anomalies, mental retardation, any learning disabilities, cardiac or neurotube defects, and then any known genetic disorders such as cystic fibrosis, any bleeding or clotting disorders, sickle cell disease or trait in the partner or in their family, and then any current medications you need to know about. And that would be, of course, you know, prescription, non-prescription, and then substance use, substance abuse, It's helpful to know that prior to pregnancy so that they can, if they need to wean off certain drugs, that they can do that prior to pregnancy. Any domestic abuse, sexual abuse, because we know during pregnancy the abuse can escalate. Get a good diet and nutritional history. Make sure they have a healthy diet prior to pregnancy and, of course, during pregnancy, and then look at their folic acid intake. Evaluate for any environmental or occupational hazards, such as heavy lifting, exposure to toxins. Make sure they're current on their immunizations, hopefully prior to pregnancy. Any risk factors or high-risk behaviors. It'll include the physical exam, like a good head-to-toe physical exam. Look at the blood pressure and the BMI, because those are two things you would hope to kind of get under control prior to pregnancy. And then if they're on an ACE inhibitor, get them off the ACE inhibitor. And then assessment of any socioeconomic, educational, or the cultural context, because there are some, religious and cultural beliefs about accepting blood products, or maybe they prefer certain genders in the delivering provider. These next two slides are just kind of show you some chronic diseases that you may encounter with women, and then, of course, their risk to the baby if they have these. And this is more if they're uncontrolled. So you can see with diabetes, they're at risk for preterm delivery, polyhydramnios with the increased amniotic fluid, GU anomalies, big babies, hypertension. They're at risk for growth restriction of the baby, preterm delivery, and then placental abruption, which can lead to maternal and fetal death. Asthma, they're at risk for growth restriction, preterm delivery. Lupus, they can be at risk for growth restriction. Sickle cell, placental abruption, growth restriction. Epilepsy, already mentioned, there's certain medications, anti-seizure medications that can interfere with the absorption of folic acid, and then they're at risk for fetal anti-epileptic drug syndrome. They have a history of cardiac disease. The baby could be at risk of congenital heart disease. If mom has an uncontrolled thyroid, the baby could have risk. And if PKU or clotting disorders. So all women of childbearing age, and this is my theory, they should be considered pregnant until proven otherwise. So go ahead and make it common practice to run a UPT, especially if you're obtaining a urine on your patients. It's very important, and that's especially true when you're prescribing or renewing medications for the patient. Encourage limited medication for them unless there's a reasonable indication, and I'm talking about the pregnant patient, because no drug is completely safe in pregnancy, and you want, of course, the benefits to outweigh the risk, and our main concern is teratogenesis. This slide just shows you the different pregnancy categories. There are rarely any medications that are in the A category, where there's, basically that's human studies done on pregnant women. So, that's not done too often. That's why you don't see a lot of A's. There are some B's, and of course C's, you're looking at weighing the risks and benefits, and D's, you want to make sure they were on contraception, and X as well. So the most commonly prescribed medications in pregnancy, and this may be in family practice, which you'll be prescribing if you see pregnant patients, but like the antibiotics, inhalers, decongestants, could be some antiemetics, antihistamines. So here's a list of suspected or proven substances, and they've been proven to, have a negative effect or suspected on the baby or the pregnancy. You can see we already mentioned ACE inhibitors, ethanol, of course, cocaine, of course, any retinol, certain antibiotics, lithium, phenytoin, and that mycinoprotol, I think that's Cytotec, and that can cause miscarriage, tetracycline, streptomycin. So you need to be aware of these medications and make sure that you're not prescribing them. And if you are prescribing any of those, that you're definitely ruling out the possibility of pregnancy. These next two slides, I came across and thought they were pretty good because they're pretty commonly prescribed medications. See the macrobid, that's prescribed commonly in pregnancy for urinary tract infections, and you can see there is a small risk of hemolytic anemia in women with G6PD deficiency. So I just thought this was kind of helpful. Of course, you can see the heparin right there. That's the anticoagulant choice in pregnancy. So you may have patients on that during pregnancy if they have a history of the protein C or protein S deficiency. For the SSRIs, that's also commonly prescribed in pregnancy. Exposure late in pregnancy has been associated with neonatal behavior syndrome. Paxil you want to avoid in pregnancy. Already mentioned ACE inhibitors, beta blockers, even though we do use that in pregnancy for hypertension. There are risks associated with it, and typically they're being followed also by maternal fetal medicine and getting regular growth ultrasounds. Aspirin, you want them to avoid aspirin, and that would be especially after about 24 to 28 weeks to avoid any kind of NSAIDs or I saw this was interesting. The Sudafed, there was a retrospective study that found an increased risk of gastroschisis, so that was interesting. And anyways, this is kind of just for you to have. I thought this chart was interesting and maybe helpful to have if you're in family practice. We know that radiation exposure has the potential to cause gene mutations, growth impairment, chromosomal damage, malignancy, even, fetal death. Large doses, which would be about 10 rads during the first 2 weeks after fertilization, can produce bad effects. And I did want to mention that time frame is, particularly sensitive to teratogens, so any of these that we've been discussing. Diagnostic radiation usually exposes the fetus to much less than 5 rads, depending on the number of radiographs taken and, of course, the site. Exposure to less than 5 has not been associated with an increase in fetal anomalies or pregnancy loss. Therefore, it is recommended to limit accumulated fetal exposure to less than 5 during pregnancy. So I thought this was kind of interesting. So these slides are just basically the prenatal screening labs and tests. So on your initial visit or initial prenatal visit, the patient gets a good head-to-toe visit or head-to-toe exam, listen to heart and lungs, abdominal exam, pelvic exam. They'll usually obtain chlamydia and gonorrhea cultures, and you can even obtain the wet prep to look at trichomonas, possibility of trichomonas. Blood type, RH, and antibody screen are drawn along with the CBC. Syphilis screening with the VDRL or the RPR. Do a urine screen, and you want to look for asymptomatic bacteremia or even the group B strep. If they have that in their urine, then they'll need to be treated prior to delivery. The hepatitis B surface antigen is typically drawn. HIV is strongly encouraged, especially in high-risk patients, and then a rubella IgG is obtained. And if the mom is non-immune, they're recommended a postpartum booster. I don't think I put on the other, but of course you want to do a sickle cell screen for at-risk patients, and if that comes back positive, you may do a hemoglobin electrophoresis. PPD, I mean, I would say if they were exposed or at risk, you can do a Pap test. Hopefully they're up to date with HPV. And then, of course, these next ones are going to be, if they've got an increased risk of cystic fibrosis, Tay-Sachs. You can do an early diabetes screen if they're obese, or you suspect diabetes, and other genetic screening tests. Basically, if if they've got any of that, you may want to refer them to maternal fetal medicine even early on for evaluation. 8 to 20 weeks, and again, this is really only when indicated. And a lot of times the maternal fetal medicine or the MFM will do the first trimester screening for chromosomal defects or neural-tube defects. So these are kind of testing that they would do. At the end of the second trimester, you'll redraw the CBC. You want to watch for anemia. They'll undergo the 1-hour glucola test, and then if that's abnormal, they'll have to undergo a 3-hour test, and that's screening for gestational diabetes. If they're Rh negative, you'll obtain an antibody screen and administer Rogan. Um, 32 to 36 weeks, you'll obtain, again, the CBC. They may need an ultrasound, HIV, again, and chlamydia and gonorrhea if they're at high risk. And really, if they've, I think it's a good idea if they've ever had chlamydia or gonorrhea, especially in a pregnancy, to screen them again at 36 weeks. You're going to usually at 36 weeks also obtain a Group B rectovaginal culture, so you're going to be down there anyways. And of course, if they're positive for the beta strep, they'll be treated during pregnancy. Prior to delivery. Here's another chart for you, and it's just the maternal labs and then what to do if they're abnormal. And I did want to point out down at the bottom, women with microcytic anemia should be evaluated for iron deficiency anemia. And they need to be treated with iron. And then I talked about the sickle cell, and you want to screen women of African, Asian, or Mediterranean descent. And like I mentioned, if it's abnormal, you want to do a hemoglobin electrophoresis. You want to do the screening for syphilis, and you can get some false positive results with those non-treponal testing. Especially pregnancies actually can cause a false positive lupus. So you would need to make sure you follow it up with a treponal test to confirm the diagnosis of syphilis. The urine culture I mentioned, you'd obtain an initial visit for either asymptomatic bacteria, and they do typically recommend a test of cure after they've been treated. And then I mentioned the Group B screening. You're going to screen their urine at every visit or dip their urine, and you're looking for protein, glucose, ketones, bacteria, all that. Chlamydia and gonorrhea, I already mentioned, should be done initially, an initial prenatal visit, and then I recommend doing it at 36 weeks. And if they're 25 and under, definitely, because they're at risk. And then the PPD that we talked about. This is another chart that is looking at the recommendations for STD screening in pregnancy, and they're looking at the CDC and ACOG. And I just wanted to point out that they don't recommend routine screening for the herpes simplex virus unless the patient has, a symptom. And of course, you want to be alert to that in the last 4 weeks, which would be about the time you'd be checking cervixes anyways. And I'm going to get into it, like I have another lecture on sexually transmitted infections. We'll get into that. So your maternal assessment, in addition to the screening and labs we've been talking about, each visit they'll have their blood pressure, look at weight gain, weight loss, edema, dip their urine, assess for, look at the fundal height or measure fundal height, assess for fetal movement. They should, from 20, usually around 16 to 22 weeks, they actually start to feel the baby move, but it does not come real predictable until after 28 weeks. However, anytime a patient complains of feeling the baby move and then not feeling the baby move, they should be evaluated. Mothers should be assessed for pain and warning signs, which I'll have on another slide for you. Trimester appropriate screening and education. Their prenatal care will consist of visits every 4 weeks for the first 28 weeks, and then usually every 2 weeks. until about 35, 36 weeks, and then they're seen weekly. Now, this is going to vary if they've got certain risk factors or they're a high-risk pregnancy. They may be seen more often, and they may be followed by OB-GYN and maternal fetal medicine. So we talked about the maternal assessment. These are just some assessments that look at or evaluate fetal well-being. And we know that if baby's moving, heart tones, that's an assessment of fetal well-being. Bundle height, because you're looking at the growth of the baby. Usually there's some, the quad screen around 15 to 20 weeks that looks at chromosomal abnormalities, and that's a blood draw from mom. They'll usually have initial dating ultrasound to determine the gestational age, and then, of course, make sure it's an intrauterine pregnancy. Typically, just in a normal pregnancy, they'll just have a level 1 ultrasound at 18 to 20 weeks looking at fetal anatomy. Advanced fetal assessments, and these are going to be, mothers or mothers with risk factors or just complicated pregnancies. Again, they could have like serial growth ultrasounds, non-stress test, biophysical profile, and that's basically a non-stress test, and then looks at fetal movement and reactivity. The MFM may be, in addition to growth ultrasounds, doing Doppler flow studies, which basically evaluates the umbilical, arterial, and venous blood flow from mom to baby. An amniocentesis, which is an invasive assessment, that can also be done to determine fetal lung maturity. Counseling and education should include fetal growth and development, what's normal, what the baby's doing at this, time in the pregnancy, changes in the mom, potential discomforts, and then relief measures. Encourage appropriate dental care. And I don't think I have the ACOG article for y'all, but you want to assess, do they have cats? And if they do, they need to avoid changing the litter box during pregnancy for the risk of toxoplasmosis, and then counsel them regarding immunizations. You need to evaluate the psychosocial aspects of their pregnancy. Usually early on, they're going to be pretty emotional, sometimes during the whole pregnancy, and they need to be reassured that, some of that's normal, that they're not going crazy. Assess their support system, and hopefully they have a good support system. And then, kind of fill them out as to how they're, if it was an unplanned pregnancy, especially how they're adapting to pregnancy, do they seem to be embracing it and getting excited about the baby and preparing for the baby. And of course, this is, you definitely want to know if they've had a history of depression, if they've been treated medically or inpatient, any history of suicide attempts, because you're going to want to watch them extra close and maybe even co-manage them with psych. This is just shows you some sources of the necessary vitamins and minerals during pregnancy. And it's important to know this, and so that you can educate them as to what they need to be eating more of. The folic acid, typically the recommendation is about 1 milligram during pregnancy, 600 micrograms. A lot of the over-the-counter prenatals have, but a lot of the prescription prenatals will have the whole 1 milligram. If they've, it should be about 4 milligrams prior to pregnancy on the girls, especially that have been on, some kind of anti-seizure medication. This is a chart from the CDC, and it shows you the different vaccines and during pregnancy, after pregnancy, like if they can get them or not. Yeah, the flu's on here. The flu vaccine is definitely recommended. You see the MMR is not, and I mentioned the rubella screening for that. That is one that you screen for it because it can be very harmful to the baby if the mom got it. I mean, baby can be fatal to the baby. But they would get the booster postpartally if they were equivocal or non-immune. So this is just some signs and symptoms of complication, and the patient should be aware of these. Vaginal bleeding, sometimes they can have some early in pregnancy, spotting. If they call and complain of it, they definitely need to be evaluated for it because they're going to worry. And, it could be a cervicitis and could potentially be a miscarriage. Any heavy vaginal bleeding, they would need to go straight to the labor unit if they're over 20 weeks, or if they're under 20 weeks, then to the ER. Any facial or hand edema, even periorbital edema, they will have some dependent edema, especially in the 3rd trimester, and especially in your patients that are up on their feet all day. Any prolonged nausea and vomiting, fever, chills, abdominal pain, a gush of fluid from the vagina, or even a continuous trickling of fluid, severe headache, visual changes, and then any dysuria or changes in normal urination. And they don't have it on here, but of course, I would say no fetal movement would definitely be one if, you're pretty far along. And I mention that because these are kind of the symptoms you're going to say, you need to be alert to these things, and so fetal movement is definitely something you want them to be alert to, and it's something you're going to ask them about every time they come in. These are just some common discomforts that can be encountered during pregnancy, and you can see it listed by trimester. So you can see early on you've got the fatigue, breast tenderness, urinary frequency, constipation. You can have an increased vaginal discharge. And then as the baby moves up, you can have more of that heartburn and less, urinary frequency. You can have some shortness of breath. And then as you get into the 3rd trimester and the baby starts to drop, you may feel some pelvic pressure. And of course, you can have some swelling. And the round ligament pain, you're most likely to encounter that. I'd say anywhere from 16 to, maybe 28 weeks, and that's just because that's when, the baby's growing and it's pulling on those ligaments and stretching them. It's important to encourage these moms that, that the round ligament pain, that they can experience that, and it can be normal. They can have some increased vaginal discharge. But this is Cook's rule. A pregnant woman, can have anything that's non-pregnant, and so you don't need to just chalk all these symptoms they're complaining of as, oh, you're just pregnant. And I think maybe us in women's health tend to be that way, probably more than maybe family practice, but just make sure you do a good assessment and evaluate if there's any warning signs. So some first trimester common complaints. We talked about the nausea and vomiting. You can encourage them because a lot of times it's worse on the empty stomach in that first trimester and when they wake up. So you can encourage them to maybe put some crackers by their bed, and then before they even get out of bed in the morning, kind of eat a couple crackers before they kind of get moving. And you want to encourage them, especially in that first trimester, to eat frequently. Definitely don't go long periods of time without eating because they are at risk for hypoglycemia. And, that kind of, anytime you've got that, the woman who faints in Walmart or whatever and finds out she's pregnant, and it was usually because they went for a long time without eating or had a hypoglycemic episode. If they do have that nausea and vomiting, of course you want to assess, and this would be kind of along with Cook's rule. They're complaining of nausea and vomiting. You really need to do a good assessment. I mean, are they like not keeping anything down? And I usually tell my patients, if it's been 24 hours and you cannot keep anything down, then you need to go to the ER for some fluids. And of course, you can do medication. There's certain prescription medications you can do. And then constipation, that's usually a common problem. Encourage, increase water intake. I know seems like a lot of my patients, they hate water, just get you some packets and mix them in there, but you've got to stay hydrated, especially during the summer months. You tend to have problems with women and dehydration, especially during that second, maybe end of first, beginning of second. Just remind them they can easily get dehydrated, and they need to drink at least 2 to 3 liters of water a day, and that's sometimes they can't grasp what that is. So you can say, the half-liter bottles, like put it in numbers, like give them a goal. You need to drink this many bottles of water. Breast tenderness and enlargement in that first trimester is normal. They have the pigmentation, they get darker in certain areas, and I just let them know that that's all kind of due to the hormonal changes, and that they will pre or post pregnancy they typically, the pigmentation will go back to normal. They can also decrease or have the nasal, like that constant congestion, even some bloody nose sometimes. Basically, the estrogen kind of dilates the blood vessels and all the mucous membranes. That's why I explain it to them, so they can, when they brush their teeth, they can have, their gums can bleed easily. They blow their nose can bleed easily. And then pitulism, that's increased salivation. You do have some girls who, I call them my spitters, who just have constant need to spit, and they'll carry around a spit cup or whatever, but just increase them. Still, let them know to still drink a lot of fluids, because that kind of helps thin it out and keeps them hydrated. They kind of think that the more they drink, the more they're going to have, but that's not true. So some potential complications, if they are having severe vomiting, it can be hyperemesis gravidarum, So they would need to be evaluated for that, check their thyroid. If they're having chills, fever, diarrhea, abdominal cramping, and then bleeding. Second and third trimester common complaints. Heartburn, encourage them to continue their frequent meals, eat every 2 to 3 hours, but avoid eating, do that rather than your 3 big meals a day. So if you just eat a little bit, a few hours later, eat a little bit, of course avoid hot and spicy foods, real fatty foods, but again, don't just chalk it up as, you're having heartburn. Make sure that, you're not dealing with somebody that needs gallbladder out, so, because that can, happen during pregnancy. Edema, varicose veins, if they're on their feet a lot in pregnancy, like they have a job that requires them to be on their feet during the day, encourage the use of the TED hose, encourage them to drink a lot of water to help, kind of mobilize that fluid and put their feet up when they get home. Constipation, I already mentioned you want to have them increase their fluids. They can even do the Miralax over the counter and do that daily. And of course, if you can manage their constipation, you can help with any hemorrhoids. But sometimes just being pregnant and that pressure, they can have hemorrhoids. Back pain is pretty common in pregnancy. If they do have those jobs where they're up on their feet a lot and they have that backache at the end of the day, you can encourage they make the belly band or the abdominal band, which can kind of help hold their belly up, which takes some pressure off their back. You can encourage, good posture, because a lot of that, they've got that weight of the baby pulling their shoulders back, and it's putting strain on their back if they've got that, leaning forward. So encourage that. They can have some vaginal discharge. You can evaluate it. If basically my rule is if it doesn't burn, sting, itch, or smell bad, then it's probably normal. So you just want to kind of tell them to be alert to those symptoms. And then, of course, if it's watery discharge, that could possibly be their water bag. Leg cramps, again, this is usually associated with some dehydration, potassium, magnesium, like electrolytes. Encourage water. I'm just a big, push water for everything, but bananas, they can even do some magnesium. Shortness of breath is pretty common. Sometimes they have to actually prop themselves up to sleep a little bit, which if they're having heartburn too, that kind of helps that. They can have difficulty sleeping, the fainting, the round ligament pain, and then carpal tunnel syndrome. They can get that as they hold on to fluid in their joints. You can actually encourage them to use the sleep maybe with the wrist supports at night. Some women have just horrible trouble with it, and so if it gets too bad, sometimes you just have to refer them to a hand specialist. But just reassure them that that's due to the fluid, and anything they can do to kind of decrease the edema. Drink a lot of water. Avoid overuse if they've got a job that they're using their hands a lot, and just reassure them that it typically resolves after pregnancy. Potential complications, they still could be at risk for the hyperemesis gravidarum, gestational diabetes, hypertension, preeclampsia typically doesn't develop till after 20 weeks. If they've got hypertension, like chronic hypertension, they're at risk for developing preeclampsia. Infection, they're at risk for infection. Premature rupture of membranes, preterm labor, miscarriage, and then placenta previa and placenta abruption. So we'll briefly talk about the postpartum period, which could be considered the 4th trimester. It begins immediately after birth. You may see patients postpartally. They may come to family practice rather than come back to their OB-GYN, or they just may be within that postpartum time frame. A little assessment acronym you can use is the BUBBLE-HE, and it's, just assess breast, uterus, bowel, bladder, lochia, episiotomy or lacerations, Homans for risk of any blood clots, hemorrhoids, and then emotions. If they're breastfeeding, you want to assess particularly their breast, but then just how it's going. A psychosocial assessment is important for the risk of postpartum depression, and of course the need for contraception, possible need for contraception. And then again, you're still, focused on health maintenance and prevention. So, and the woman who is not immune, of course, she would do the rubella, or if they just had some immunizations that they needed that were contraindicated in pregnancy. So just to talk just briefly about breastfeeding, as a provider, if you're seeing postpartally and they're not breastfeeding, it wouldn't really apply. But if you're seeing them prenatally or just in the childbearing years, like preconceptionally, or you're seeing them postpartally and they're in the middle of breastfeeding, then you want to encourage those efforts. Know the benefits and encourage them to breastfeed, especially for the first 6 weeks. If they're having breastfeeding difficulties, you can assess using that LATCH acronym. If they're having nipple soreness or cracking, the baby might not be latching on properly, so you can assess that. Audible, you need to hear the audible swallowing. They may have a inverted nipple, so they can use nipple shields. Assess the mom and baby's comfort and the holding position. Contraindications to breastfeeding include HIV, active TB, if mom's on chemo, radiation, has illicit drug use, and then if the baby has galactosemia. Potential complications, we're going to talk about mastitis in just a second. This is just a picture. I had it, I think, when I taught undergrad, but I just like, because it kind of hones in on the potential complications postpartally, and then your risk factors for developing them. If they've had a C-section or prolonged labor or rupture of membranes, they could be at risk for infection. So I just like that picture. So postpartum infection, these are possibles. It could be a reproductive tract or puerperal infection, and it could be some endometriitis or pelvic cellulitis. Endometriitis could be if there was a retained placental fragment or wound infections. It can be, if they had a episiotomy or laceration, they could have a perineal infection or the C-section wound, urinary tract infection, especially if they had a catheter and more than one catheter, and then of course mastitis. Just to briefly mention postpartum fever, which you could possibly, be seen and working up. It's the most common cause of admission post-delivery or hospital admission post-delivery. And you want to tell them that it's usually a temperature greater than 100.4, occurring after the first 24 hours or on any days of the first 10 postpartum days. And I mean, if they call you and they're running fever, I wouldn't get, finding out what the numbers were and all that. I just have them come in and work them up. And you can use this, I've always used this to try to, rule out and assess for the or look at the differential diagnosis: wind, water, wound, walking, and what did we do. The wind, would be, you definitely want to listen to their lungs, and if you're suspecting like a pneumonia, water would be UTI if you want to assess their urine. Wound would be the surgical site or perineum. Walking would be DVT or pulmonary embolism. And then think of the things like, what did we do? Sometimes if they did get a lot of Cytotec to control bleeding or bleeding associated with acne, they may have gotten Cytotec, and they can actually spike a little temp after that. But just kind of think of the, the interventions that were done to them during the hospital. So that's just a little acronym. Assessment, I'm not sure what that is on my screen. Assessment of mastitis. It's usually unilateral, and it's like an isolated hot spot really on the breast, and you can see in that picture. I'm not sure what's wrong with my slide, but I think I have. This just shows you the differential diagnoses: engorgement, mastitis, and a plugged duct. And engorgement is typically bilateral, and their breasts they hurt and they're just red, swollen, painful. But mastitis, is going to be, they're going to have some systemic symptoms. It's going to be unilateral, localized. So this is just kind of tell you the difference. Postpartum hemorrhage, really you would probably it'd be late, because early is going to be, the first 24 hours. They can have pelvic or back pain. They can present with that. Uterine tenderness. They can have just bleeding that's maybe not heavy, but just going on constantly for more than 2 weeks. Fever. Some potential etiology would be uterine acne, and that's typically your most common cause of early postpartum hemorrhage, just where the uterus maybe is fatigued from labor, and then maybe the use of Pitocin, but then that's basically just a relaxation of the uterus, and retained placental fragments, and lacerations can be common causes of late postpartum hemorrhage, even coagulation disorders maybe that just have never been diagnosed. So this is just a little chart of signs. Like I mentioned, it can be excessive, or it can just be constant, persistent bleeding. They could have a boggy uterus when it's related to acne. Usually the uterus won't undergo the normal involution, so it might be a little bit higher than it should be. You could do a perineal exam and see if they have a big hematoma. So make sure you assess all that. Also, it's a good idea to do a CBC. I mean, it's going to be a little bit lower, but maybe you can get your hands on the one before they left the hospital. Of course, assess for signs and symptoms of hypovolemic shock. There's some oxytocin medicine and uterine stimulants that can sometimes be used, but usually if you're dealing with uterine or retained fragments, I mean, you can possibly sometimes go in, do a speculum exam and see something, get it out, or do a bimanual and get it out, but sometimes it requires going back in, doing a D&C. It could be endometriitis, so of course you'd want to do some antibiotics. And then if it's a suspected coagulation disorder, then you could refer to hematology. And just to, I mean, I'm sure you're aware of the risk of thromboembolic disease, but you know it can be, well, not common, but it can happen after pregnancy, during pregnancy, and these are just some risk factors. And you can see the factor V, protein C, protein S, which some of that's been associated with repetitive miscarriages, preeclampsia, because there's been a lot of studies on that. So you see that some patients, know if they have protein S or protein C because they've been tested for it, and some of them might already be on heparin. Sorry, I went blank. On heparin, post-delivery to prevent it. But just be aware of those. I'm just going to I just have two, I think, slides left briefly on postpartum blues. It is pretty common, and it can occur, it says 3 to 6 days, but I know there's been lots of times I've rounded and, come in and they're just falling apart and they're just sad. Just let them know that, a lot of that is hormonal and can be normal. But of course you want to kind of see what's going on, because some of them just might not know why they're upset, or maybe it's kind of like, basically they've anticipated this event and it's kind of like it's happened and maybe it didn't go the way they anticipated, so kind of evaluate all that. Reassure them that, it does get better, but that you're available and they need to call you if it doesn't. And then, of course, make sure they've got some good support at home, because that's so important. Postpartum depression, that usually occurs a little bit later, but women who've had depression in the past are increased risk, and people who've had postpartum depression are definitely at increased risk. Sometimes it requires the use of antidepressants and hospitalization. It can affect the bonding with their baby, and this is another good reason for them to have some good support people at home, because sometimes they recognize it and the patient doesn't recognize it. But, you want to monitor for the possibility of suicide, homicide, psychosis, because we all know just from stories in the media that it can be bad. So be aware to those in your postpartum patients. And postpartum psychosis, usually there's an underlying psychiatric disorder. But you can see at risk for the younger age, first babies, and they can typically have a family history of psychiatric illness like schizophrenia,